This is an excellent example of the severe blistering variant of erythema multiforme that goes under the name of the Stevens-Johnson syndrome. Now, as Dr. Al-Sudani says, Stevens-Johnson syndrome is usually associated with a drug. The characteristic feature is not only blistering lesions like this, but mucosal involvement, particularly the lips and the eyes, although other mucosal surfaces such as vagina or genital epithelium can also be involved. Typically, the rash will come on often 2 to 3 weeks after a new drug is started, especially if someone's being sensitized to it for the first time. If obviously someone has had a drug reaction to this particular drug in the past, then it will come on often within 24 to 48 hours of taking the drug, if not sooner. Often patients have vague upper respiratory tract features, first of all, and this is for 1 to 2 days prior to the onset of the rash. And when they do get the rash, it begins initially as symmetrical erythematous macules, often with a small target-like lesion, particularly in the palms of the hands and the soles of the feet. Now, in a target-like lesion, you have a dark central area, a lighter peripheral, and then sometimes a slightly darker outside area again. It's this central area that often is the area that blisters, because that's where most of the damage is occurring at the dermoepidermal junction. And so you get separation with a thick wall of epidermis on the surface of the blister. So this usually gives you intact blisters like this. So if we just take a look at an enlarged view of this, it will give us an idea of the size of these blisters. Here you get an idea of perhaps target-like lesions. Now this is quite extensive blistering. Let's have a look at some other cases of Stevens-Johnson that we have here in the atlas. This case here, or perhaps this one, shows the fairly extensive mucosal lesions that you can in fact get. You can see how these lips are glazed and blisters have occurred. The limbs here may show us target lesions. No, this is extensive blistering again. Look how thick-walled and tense this blister is on a red base. This particular case here, it was an unidentified medication. Usually it's antibiotics, particularly sulfonamides, and also the non-steroidal anti-inflammatory drugs. And sometimes the anti-epileptic drugs will do this as well. Let's pop back and have a look at some of the other cases. Here's another example here. And this one gives you an idea of how extensive this rash can in fact be. Let's see if we can have a look at this full size. No. Again, this one is showing fairly extensive blistering as well. The target lesions are best seen perhaps in ordinary erythema multiforme. Erythema multiforme, let's just have a look and see if we can see some target lesions in that. Ordinary erythema multiforme is most commonly seen after herpetic virus infection, but it can also be seen after mycoplasma chest infections, and again as a drug reaction. You can see there's many cases in the atlas here. Let's have a look at this one here. Yeah. This gives a better idea of the target-like lesions. You can see the dark central area, the surrounding erythema, but lighter. Perhaps even a better example in this image here. Again, you've got that dark central target-like area. And when you're going to start to get your blistering, this is where you will in fact get it. So some cases of Stevens-Johnson syndrome can merge almost into the more severe variant of a drug reaction called toxic epidermal necrolysis. And if we're going to look at toxic epidermal necrolysis, probably the best pictures I can show you are some of these ones from the My Skin Consult website. If you have a severe drug reaction with toxic epidermal necrolysis, you can see how the skin here is virtually peeling off. See how you've got erosions here? Just the slightest little bit of pressure here will cause that top layer of skin just to peel away. And there's virtually full thickness damage to the epidermis in toxic epidermal necrolysis. And these patients have to be treated almost like a burn, because it's virtually a full thickness burn that they in fact have. Here's another image here that shows you look at the severity of the eye involvement here, the bleeding from erosions in the skin, and the lip involvement here as well. And this person's skin was tender all over. It's another classic feature of toxic epidermal necrolysis. So there are more severe variants of the Stevens-Johnson syndrome. And in that severe variant, because of the severity of the eye involvement, you can have scarring and synechia, where the surfaces of the conjunctivae stick to the sclera of the eye as a permanent type of scar. Sometimes also in toxic epidermal necrolysis, the process can involve the lining of the throat and even the esophagus, and even the tubes, the bronchi leading into the lung. And this, as you can imagine, accounts for the potential mortality of about 30% in some cases. So, Stevens-Johnson syndrome, you think of it in a situation where someone has a sudden onset of a blistering eruption a few days after starting a new drug. And you may see some target lesions like this initially, but usually it will go on and develop the mucosal involvement. And whenever you see that tender skin with mucosal involvement, consider that they may have Stevens-Johnson. In early cases, high-dose oral steroids may help, but once it's established, the steroids don't really help much at all. So it's important these patients are recognized early and the offending drug is withdrawn, or else you will end up with a case like Dr. Alcidani's. But of course this patient, though the rash came on within 48 hours, it was recognized what it was, and the rash was, the offending drug was in fact stopped. In this case it was a sulfonamide, and these are probably the commonest oral antibiotics that do cause the Stevens-Johnson syndrome. Thank you very much. I'd like to thank Dr. Alcidani for putting up this and many other very interesting cases.